let's shift completely from trauma. That was more sort of reflective, that type of a presentation. This is a little more nuts and bolts, where we talk about post-radiation bladder neck and proximal urethral stricture challenges. Um, I would say that this is an area that has undergone great evolution over the past 10 to 15 years. Again, here are my disclosures. When you think about patients that have undergo any type of urethral reconstruction, I would say that 10 to 15 years ago, when I finished my training, to now, how we manage those patients are, I think, diametrically different. Bulbar strictures back, again, a decade ago and beyond, it was said, well, listen, the gold standard for repair is cut out the segment that's blocked and just sew two ends together. That was what was said. And that seemed pretty reasonable. It's like a vascular type anastomosis. You just sort of resect a section and then sort of bring two ends together. I totally get it. The urethra has a dual blood supply. The idea that the antegrade blood flow comes through bulbourethral and dorsal arteries, retrograde blood flow through the glands, it supports an anastomosis. But then as you think it through, it also perhaps creates a problem in the event that you have a failure of that anastomosis, how to then manage an area that has less blood flow because you transected the urethra and did a primary anastomosis. Once you change the urethra in terms of its blood supply and blood support to an area of stricture, you then create sort of the consequences of that initial decision. Nevertheless, 10 years ago, and I was lucky to see I have several residents that trained that trained when I was junior attending, would say that this was very accurate. 10 years ago, this patient in my practice underwent an excision with primary anastomosis, no question. And I would show at meetings like this these nice, sexy pictures of the urethra being, patent after that type of a repair. And I owe a lot of that to sort of my mentors as I trained. I trained with Al Morey in Dallas, Texas. Al was this huge proponent of the concept of transecting urethroplasty. In fact, back in 2010, he wrote this sort of series of his own patients where he said, listen, you don't need to really do anything other than excisional. Most reconstructionists, or many reconstructionists, I think today would look at a longer segment defect and say, hey, listen, this is something that I would put in a substitution for. I would put a graft in for this type of a patient. But no, in the Morey data, in the Morey series, patients with up to even a 5-centimeter stricture of the bulbar urethra would undergo a primary anastomosis. And the argument was that, the success of that repair is high. However, soon thereafter, there were series that came out that really questioned not necessarily the patency of the repair, but what the unintended consequences were of the repair. And does it or does it not sort of lead patients to, let's say, sort of a more suboptimal erectile function following an excisional repair? And this was, Brad Erickson, who, is a good colleague of mine now leading the reconstructive unit at the University of Iowa. He was a resident when he did this with Chris Gonzalez, who was at Northwestern, now is at Loyola. But Chris Gonzalez had this series where they showed that the erectile function scores in transecting repairs went down. Tony Mundy's really a titan of reconstructive urology. He's a forefather, living legend. And the concept that I think Professor Mundy brought out, as a British surgeon who's quite renowned, was, listen, we might not need to do excisional repairs on all these urethral strictures. Instead, maybe we do a non-transecting repair where we incise one part of the urethra, and if we need to, we also incise the other side without transecting it completely. Put in a graft on one side or the other or both, and then repair the urethra that way. So he sort of presented that concept. Brad Erickson graduates, does a fellowship, and then coalesces a multi-institutional group where they really look at transecting versus non-transecting repair and show in a multi-institutional fashion that erectile function results are compromised with transection. So, how is that related to radiated strictures? That's a little background, is what I would say, into the conversation over radiated strictures. Let's agree that a lot of radiated cancer survivors struggle with three problems: incontinence, erectile function, and maybe obstruction. So that's, I would say, the bane of the existence of any urologist, is to manage a reconstructive patient with a radiation history, is because of the confluence of those problems. And historically, it was argued that radiation damage to the urethra might necessitate either a chronic catheter, if there's, urethral obstruction or stricture, or even urinary diversion. Again, let's look at Mr. Mundy. So Mr. Mundy, again, around 15 years ago, makes this argument in a review paper without really doing sort of a single institutional or a multi-institutional analysis. But the idea of, hey, listen, could you transect the urethra and sew an unhealthy end to another unhealthy end? Again, unlike the non-radiated person. Or do you put a graft in, or do you do a dorsal graft? What can you do? Whatever you do, though, the question is, you have to remember those three problems that radiated survivors have. They have erectile function problems already, but most importantly, they have continence issues that you need to sort of keep in the forefront of your mind, or they may develop a continence issue after you unobstruct them, okay? So, again, Al Mori's series with Chris Gonzalez, they then come through and say, well, radiated series, we'll sort of look at patients and do excisional repairs. The success rate's around 70%. And then, Dr. Fish just gave us a great presentation on perineal urethrostomy. At her center at Hamburg, they looked at this and said, well, listen, a ventral onlay, technically, it's not a true transection. It's a one-sided sort of urethrotomy, and then we extend that urethrotomy all the way as proximal as we can and deploy a buccal graft, and then close the corpus spongiosum such that, the urethral blood supply somewhat supports the graft that's placed. This series looked at some level of continence. The first series that I showed you, the Mori-Gonzalez series, didn't really report on any continence outcomes, and this series shows that patients developed a small percentage, 10% of people developed de novo incontinence, but I don't think it went through the details of how continence was managed after patients were unobstructed. We then had this idea, Dmitry Nikolovsky and I are close friends and collaborators, where we said, well, listen, what if we were to sort of look at radiated patients, and instead of placing a graft ventrally, we can then extend the urethrotomy all the way to the bladder neck if we need to, and deploy a buccal graft in dorsally. And so, multi-institutional series that we coalesced over several years of follow-up, 10 institutions, 80 patients, minimum of 1 year follow-up, and the success rate was around 80%. But that represents all comers. So, why is this different? Why is the bladder neck and the proximal urethra different than all the things that, are what I would call background information as we sort of head into this problem, especially in the radiated survivor? Well, let's go through some nomenclature. So the SIU came together with nomenclature. There's the term stricture. Stricture really should only apply to patients that have a corpus spongiosum. If you don't have a corpus spongiosum, that's not stricture. So you wouldn't call it a bladder neck stricture because that area doesn't have corpus spongiosum sort of around it. Like that, the anterior urethra has corpus spongiosum. The membranous urethra does not. The membranous urethra would not be considered sort of a urethral stricture bed. Posterior urethral stenosis, however, is a little bit of an umbrella term that covers the posterior urethra, including the membranous, where there is no corpus spongiosum, and it goes all the way to the bladder neck. That's an umbrella term. Bladder neck contracture is a term that we use to define patients that usually, almost always, I would say, have a prostate in situ, that often undergo like a BPH procedure that have narrowing of their bladder neck. That's a bladder neck procedure, or a bladder neck contracture. And then the final term is one that we probably don't use enough. It's the post-prostatectomy survivor that develops narrowing of their bladder neck. The most appropriate term for that I would actually call is a vesco-urethral anastomotic stenosis. So we sometimes interchange these terms, but this is probably the best way to maintain consistency in the nomenclature, is to use the terms as appropriate based on the patient's sort of history. So, thinking about the proximal urethra and the bladder neck area or posterior urethral stenosis area in the radiated survivor, what could we do? if you think about it, these are all the things that I think are done in the community or at academic centers. There's repetitive dilation, there's mitomycin or steroid injections, there's perineal or robotic reconstruction, there's abdominoperineal reconstruction, which I would say is a big step if you're really going abdominally and perineally to manage a problem. But ultimately, management of radiated patients of the proximal or the posterior urethral stenotic area is often conflated with non-radiated patients when we make decisions. Let me explain that. It's not the same. So when you confront the problem and you see someone with, let's say, a vescourethral anastomotic stenosis in the radiated survivor, how can that patient best be managed? These are all the things that you think through. What are their goals? What's their continence status? What are their continence goals? What's the etiology? These are all the things that you're thinking through. And ultimately, once patency is established, especially in the radiated survivor, you then have to manage their continence because usually they're unobstructed, and once they're unobstructed, they leak. Oftentimes, I know we're going to have some lectures, and I have one on artificial sphincter later during the course. I would say that oftentimes patients with dramatic leakage that have been radiated graduate to an artificial sphincter. So if you're going to place an artificial sphincter, remember that picture I showed about the dual blood supply. You know, it could be argued that placing a cuff around an already sort of questionably ischemic urethra might lead to a lesser survival of that artificial sphincter cuff. Okay. So we've published on bladder neck contracture. We've had several series where we've looked through sort of, repair. Nora Baker was in the audience. I give her full credit. Everyone give Nora a big hand. She wrote this paper that's on right here. Nora, raise your hand for everyone. There you go. Yeah. So Nora was one of our residents who did a fantastic job in this, and the idea and the concept is pretty straightforward. You make lateral incisions in the bladder neck, and you create a huge channel, not to fit a 32 French resectoscope like Dr. Krambeck said, but probably to fit in like a 24 to 26 French resectoscope. And once you've done that, maybe that's all it takes. 70% success rate with one procedure, 85% success rate with two procedures. You know, you ask what's the benefit of perhaps doing mitomycin C? Mitomycin C is an injectional strategy. We can do this. If we do it, is there harm? Well, this is a great multi-institutional study done by the Terns Group. Yes, there is harm. Prospectively assess patients that undergo mitomycin C, 66 patients. You're signing up a patient for a minimally invasive procedure. 4 patients in that series graduated to cystectomy due to bladder neck necrosis. 4 patients. So it's a tough pitch to tell a patient this is a minimally invasive procedure and then graduate 4 of them to urinary diversion. And that's what that series showed. After that series, we never did mitomycin C. Here are 2 videos. One, I give huge credit to Brian Flynn. Another video, good friend of mine, Lee Zhao. Here are ways that people have talked about fixing bladder neck problems, but these are for bladder neck contracture. They're not for the radiated survivor. So in the video on the top right, the idea is to anteriorly incise the bladder neck, create a YV flap, and advance the V forward and close the bladder neck such that it's patent. On the video on the bottom left, it's to open the bladder and then resect parts of the stenosis in the trigone area and inlay a buccal graft. Again, though, this technique not really shown to my knowledge in radiated survivors. Newer technique. This is something good friend of mine, Nick Warner at the Mayo Clinic, had this idea. He's like, well, why don't we just do this all minimally invasively? We'll take a laparoscopic instrument, we'll go in through a transurethral sheath, we'll throw stitches in after making lateralizing cuts. I know Simhan and Mori and all those guys have published the idea of doing bladder neck incisions. We'll do a bladder neck incision like this, and then once we've made our bladder neck incisions, we'll take a needle trocar, a laparoscopic 5mm needle trocar that can fit through a transurethral sheath, and place 2 stitches, one at 3 o'clock and one at 9 o'clock. And then we'll place those clips to sort of bring 2 ends together. Sounds great, right? But we haven't published it in radiated series. This too hasn't been published in radiated patients. This is a great paper on bladder neck contracture management, also by Dr. Fish's group, where a T-plasty is done, where a T-shaped incision is done after the bladder neck area is resected anteriorly. and the urethra is brought to, or the bladder neck is sort of brought together with reconstruction. We have done all of these techniques at our center. We have done all of these techniques in non-radiated people, and we have lived and learned that many of them fail in the radiated. We have lived and learned that many of them fail. So this is why we've lived and learned that radiated have failed. You love honest reporting where there are disastrous outcomes. This is a Mayo Clinic series where robotic patients were stratified based on radiated, BPH, or radical prostatectomy survivors. And the success rates of the radiated patients are dismal. And that is a robotic series that, huge credit to that group, because ultimately it informed my practice too. We have largely gone away from radiated bladder neck patients because it hasn't been shown in contemporary literature to have great sort of outcomes. So coming back to some of the collaborative work I've done with Nikolovsky and others is the idea that, well, if someone has post-prostatectomy incontinence with obstruction, could you go with a dorsal graft, rotate the urethra, and sort of make a dorsal urethrotomy, and then place a graft in the space, and then sew it up? That's hard, right, to place the proximal stitch. You would say, how are you going to see that? Well, now there are lighted urethral retractors where you can put a light in the urethra, and there's laparoscopic instruments where you can actually take a laparoscopic suture and throw it in an open operation so that you don't have to take a needle and bend it and try to get it into a tough space. And look at how low the bladder neck is. In the radiated survivor, the bladder neck is actually perineal. It's low. It's not amenable to an abdominal robotic operation, which is perhaps why the outcomes are what they are in those types of patients. So we've had great success. This was recently published in the Journal of Urology, months ago, and the survival of the repairs are actually pretty good. And so this is the model that we now follow. Patients have, either an injection, usually done elsewhere, or a deep transurethral incision. We graduate them to a transurethral incision, and the reason why we're doing that is we are now prospectively studying radiated survivors specifically to see if there's any benefit in this procedure. And if there isn't, we bypass to perineal reconstruction with the buccal graft for substitution. We have largely abandoned robotic operations in radiated patients. But this preserves the urethra in order for the urethra to then get a cuff later, because the cuff landing spot is distal to where you're placing your graft. Your graft is way more proximal than where you were going to place any artificial sphincter cuff. All right. So here's some closing thoughts. Robotic reconstructions, sexy. It's eye-catching. It yields, however, suboptimal outcomes. We do robotics. We just have moved away from doing it in radiated patients for that problem specifically. Perineal non-transecting reconstruction, I think, offers patency, but it also preserves the urethra for a future artificial sphincter. Thank you.